Hey guys, in this video I'm going to show you how it's like to be on call for 24 hours as an anesthesiology resident, so stay tuned. What we do on calls, we take care of all the code blues, we take care of all the level 1 alphas, and we just do scheduled cases or any sort of other emergencies that come in. So stay tuned. I also want to give a quick shout out to my friend Jacob, who's a co-resident. He helped me record a lot of this, so check out his Instagram and his YouTube channel. He has some awesome travel vlogs, and I hope you like this video. First, I want to start off by showing you what I have for breakfast, and it kind of gives me a nice little boost throughout the day. And I think that's the most important part of my calls, what I'm eating throughout the day and how it helps me sustain my energy. So stay tuned. So I like to start off my day with having something that's more on the low glycemic index of things, and a green smoothie is actually really good for this. I've been doing celery lately, and I usually try to make about 16 ounces. So you grab about 10 stalks, blend them up, and then stick them in a cheesecloth. Yes, it does take me about 5 minutes to make this, but getting the zinc, the potassium, and adequately hydrating myself for my call and for the rest of the day makes a huge difference. So you need 3 things before your call as an anesthesia resident. I usually grab my Twitch monitor, it tells me how relaxed the patient is under surgery, stethoscope, which is always handy, and a pager just to make sure I know when to go to my code blues and level 1 alphas. Once I get to work, I usually check the OR board, and as one of the upper levels, I'll usually take the acute pain pager, take care of any consults, and I'll be assigned to a room in the morning and take care of any scheduled cases or any emergencies that have been going on throughout the night and relieve that resident who is taking care of that emergency. First thing I do when I get in the room is I make sure to load up some patient information to go over their history and physical, any sort of lab work that they've had done in the hospital, and I take a look at their comorbidities and prior surgeries that they may have had. And I look at the medications that they received during those prior surgeries, and if they had any sort of perioperative outcomes, and how I can prevent anything like that. Next, I'll start with my machine check. And the first thing is you make sure that all of your monitors are working, and your monitors usually consist of 5, your EKG, your end-tidal CO2, your pulse ox to make sure the patient's oxygenating, blood pressure, and temperature. After this, I'll go to my airway setup, and for every patient it varies depending on their height, their weight, their age, their gender, their comorbidities, and usually have a basic setup that you follow, but again, these things can change. The size of your blade can change, the size of your oral airways can change, the size of your endotracheal tubes can all change. So based on the patient's history, physical, and their height, weight, and their age, you kind of customize a plan for each patient. After completing my airway setup, I'll move on and make an IV kit. After we've induced anesthesia and given our drugs, we usually like to place an extra IV, which is going to help us adequately resuscitate the patient as they're going through the surgery. After setting up my IV kit, I'll go ahead and pull up my drugs that I'll need for the case. Now, for every case, you're going to be using pre-medication to help the patient with any sort of anxiety and to help increase amnesia throughout the case. That way the patient doesn't have any recall. And you can use an anxiolytic such as Versed to do this. And you're also going to be using a bunch of other drugs that will help with sedation, that will help with induction, that will help with maintenance of anesthesia and emergence of anesthesia. So these drugs that I'm using today, I'm going to be using propofol, which is a hypnotic and sedative, fentanyl, which is an opioid, rocuronium, a muscle relaxant, lidocaine, and Versed. And you can see me pulling up drugs here. We have a safe label machine, which ensures extra safety when we're labeling and pulling our drugs to make sure that we have the doses correct and we have adequate times and dates for all of our drugs. So before providing anesthesia and inducing anesthesia, you start off by reviewing the patient's vital signs one last time, and that way you get a nice baseline of where the patient's starting at, and you can compare it to once they get their anesthesia. So you start off by looking at the heart rate, you check at their oxygenation, and then finally you look at their blood pressure. And also you'll see their temperature and their end tidal CO2, and at that point you're going to be ready to induce anesthesia. After finishing my case, I was sitting getting some paperwork done when I got a level 1 trauma alert, which means that a patient could possibly have a gunshot wound, and here on my pager it describes to me where the patient may have been injured. That way I kind of have an idea of what sort of resuscitation and what sort of airway equipment I should grab as I'm going to the Alpha 1 in the trauma bay. After going to the level 1 alpha, a colleague and I went up to a code blue and helped resuscitate a patient by intubating the patient, helping them get over their hypoxic respiratory failure. In addition to that, we had some other team members do compressions as well. But now it's time to get in the call room, try to take a nap, and do some more cases. Thanks for watching this video. Please check out my channel, like, comment, subscribe, and hit that notification button, and I'll see y'all in the next video.